That's a wrap on day 3 of Scientific Sessions 2021. But don't worry, you can still catch all the great programming. Hello, I'm Kara Moore with AHA TV.
And I'm Trey Johnson. What an incredible 3 days of programming we've been able to enjoy. Let's look back at some of the highlights from Monday. A survivor's story, an incredible start to the closing session as attendees got to hear from a cardiac arrest patient.
It was a normal day. I was with my daughter Daphne at a squash tournament in Cincinnati, and tournament went well. Then we were at dinner that night with her 2 coaches, John White, Gina Stoker, and then all of a sudden at dinner, I keeled over. No symptoms, no warning, just all of a sudden just dropped. And Gina, within 20 seconds, fortunately, called 911. John fairly immediately started CPR. And obviously both of their prompt action is a big part of why I'm sitting here talking to you. Well, one of the things that the doctors and the nurses told me in the hospital is they said that I probably wouldn't have survived if I hadn't been in such great physical shape. And I think that's a really important lesson for people in general. You know, the better shape you're in, the better your prognosis in all sorts of cardiovascular or other diseases. And we can obviously each do our best to be in as good shape as we can. And I was fortunate to have had the opportunity to do a lot of training in the previous 5 months.
Following that, we took a deeper dive into some of the trending topics.
So I think that this data is totally reassuring. It's exciting. I think that we can say to our surgeons, perhaps we can consider earlier surgery. And in the worst case, if somebody's bleeding or has active needs emergency surgery, bentracimab may be a possibility.
Michael Liu, another med student, this time from Harvard Medical School, presented an excellent analysis about how mortality compares between safety net and non-safety net hospitals in the United States for cardiovascular conditions, and how the use of post-acute care differs between those 2 hospital systems. We've actually achieved better equity between safety net and non-safety net hospitals in terms of survival, but not in terms of the use of post-acute care, which is so essential for improving quality of life after surviving a major event.
For the Quality of Care and Outcomes Research Scientific Sessions, a deeper dive into global cardiovascular outcomes. Among those, international collaboration for using observational and randomized data to deliver population-based recommendations to optimize cardiovascular quality and outcomes, and future direction on integration of evidence-based practice and health informatics to achieve cardiovascular quality and outcomes.
If you break it down to the countries with the highest numbers of cardiovascular deaths worldwide, we see China, India, Russia, still the US up there, Indonesia. And if you look a little bit beyond these 5, you're going to see a big roster of mostly middle income and some low income countries. Improving access to quality and effective care is really key to tackling the global CVD crisis. So yes, it is improving access, but it has to be access to quality and effective care. How is it that you institutionalize culture and capacity for quality improvement across all levels? This is to some extent already built into some of the building blocks and frameworks, like from the WHO for health systems. They give us all the system building blocks. They tell us we have to have access, coverage, quality, as well as safety, and that these things together will lead to the improved outcomes that we're looking for. The real aim of this is for us to learn from each other through outcomes research. This is a universal aim, irregardless of where you are. All countries are seeking value for their healthcare investments, and we need that information to be able to make the best healthcare decisions, and more importantly, to deliver high quality patient-centered care and improve patient outcomes at low cost, not no cost, low cost, which I think is the holy grail.
And I would recommend to prioritize funding and development of international partnerships based upon the conditions where cost-effective interventions exist to close those implementation gaps.
We often recognize as investigators that there are ongoing challenges in our health status and quality programs in our country. However, what can we learn from this? And I think a key example would be something like shortening door-to-balloon times, which is a key strategy to improving outcomes in STEMI. And with this QI initiative in mid to late 2000s, nationally, we were able to improve the door-to-balloon times. Our target set at less than 90 minutes, and from less than half the patients in 2005 to over 90% of the patients in 2010, in a very short period. And tracking the outcomes of similar patients in this period found that there was a progressive improvement in outcomes with progressively shorter door-to-balloon times, substantial improvement in outcomes at an individual level.
Your chance to get expert advice in customizing your career. Early career attendees got a chance to ask panelists about issues, events, and influential colleagues and mentors that have influenced them and contributed to their career choices.
Having a relationship with an oncology partner is important, but perhaps I'll go one more step to say, finding that one person within that division who will support you at the beginning of your career would be key. And when I started on faculty about 12 years ago, I found that one person who has then supported all my recruitment and patient referral, because we don't have access to many of these patients if you want to really study the whole spectrum of risk in cardiovascular disease in these patients.
The other part I wanted to just encourage a lot of the trainees on this discussion is also about really taking charge of your own education and regardless of the formal curriculum at your institution, there's so many opportunities out there, both from a scientific training perspective, but also from a clinical perspective. And for me, a lot of my collaborators on the oncology side who are also clinical mentors. So I shadowed them in their oncology clinics when I was a cardiology fellow. And I found that really enriching, both from just like learning, okay, this is how they think about, when their patients are on these trials and what are the trials that are happening at our institution, like learning firsthand from the oncologist. And there you're at the front lines of, seeing when cardiotoxicity pops up, like you might be the person they asked because you happen to be there. What do we do with this cardiology problem that's popped up, in our cancer patient?
Recent scientific advances in cardiovascular single-cell biology are providing insights into understanding ischemic heart disease. There's also promise for potential therapeutic strategies for tissue repair and regeneration.
We really generated now a multi-omic human atlas of myocardial infarction, including spatial but also epigenomic dimensions. And I think this data set will be quite interesting and a good resource for the whole community.
We identified a unique population of cardiomyocytes that is enriched in regenerative heart. And in response to stress, this cardiomyocyte can activate a protective mechanism needed by NRF1, which can help the cells to mitigate the oxidative and proteinated stress. And this stress response is required for heart regeneration.
We identified 13 atherosclerosis-associated cell states. These exhibit similarities in gene expression programs related to ECM organization, angiogenesis, and cholesterol metabolism. We also show that the small cell endothelial cell states are most enriched for CAP-GWAS genes, and that the regulatory elements of small cell endothelial cells are most enriched for the CAP-GWAS variants. And I'm again, very excited that with this information, we can start to also predict the cell type of action for the CAP-GWAS loci. And
interest remains high with COVID-19 and how it affects patients. An impact of COVID-19 on the pediatric, young adult, and congenital heart disease communities, doctors are sharing lessons learned.
When you look at this risk-benefit analysis, in either sex, looking for every 1 million kids that you would immunize with this vaccine, you prevent over 50,000 cases, about 200 hospitalizations, 130 cases of MIC, and several ICU admissions. And when you compare this to what we see with other preventable vaccines, COVID per year has caused more deaths than other things that we recommend and actually mandate vaccination of Hep A, meningococcus varicella, chickenpox, and rotavirus. And so COVID-19 vaccines now are AAP recommended. AAP recommends all children and adolescents 5 years of age or older without contraindications get this. Any authorized vaccine is appropriate. Kids with prior infection should also get it, and this can be given in conjunction with other vaccines, not to slow things down. So last slide to summarize, COVID-19 is a childhood disease. It is now a vaccine preventable childhood disease. Essentially every child in the United States and probably on Earth will be infected with SARS-CoV-2 or vaccinated. So this choice not to be vaccinated is not a risk-free choice. And the public health implications of vaccination of everyone in this country and in this world are enormous.
There's also the best available treatment study that was done, which is a worldwide study being led out of the UK. And this study has looked mostly at the use of IVIG plus steroids in their initial analysis. And while this initial study has not shown a difference with IVIG versus IVIG plus steroids, there are certainly multiple studies that have come forward afterwards that have shown a benefit to intensification of therapy initially in these patients. Those studies have been done with IVIG plus steroids. There's an increasing trend to give patients 2 treatments, IVIG plus another anti-inflammatory from the get-go, especially those in the ICU.
It's very, very important that you communicate frequently and intensely. The hospital set up a noon phone call with the leadership, which was about 50 physicians and other healthcare workers every day at noon. And that was maybe the single most important thing that they did, because everybody was on the same page and we knew what was going on. Then how to deal with unusual problems, such as we had a COVID positive patient, a teenager in the ICU who needed a VAD, and the surgeons were not interested to do this. This was at the very beginning of the pandemic. I had enrolled an adult cardiac surgeon with the most VAD experience, so it wasn't the pediatric heart surgeons. And you know, it was difficult to talk to that person. In the end, it was done, and the outcome was good. But it's not something that you're actually trained to deal with or you're dealing with. And then you're dealing with staff members who have a lot of problems because of the pandemic, or simply are afraid to come to work. So you do have to, this is a time where you have to spend more time with everybody on your team. It is a warlike atmosphere where the unknown is actually harder than the actual hardship.
AI and smart monitoring is having an impact on early detection and treatment of atrial fibrillation. Let's hear from panelists on the role of this technology.
How to do artificial intelligence. So artificial intelligence took, particularly for a cardiologist that is not a programmer with a background, it really took us a lot of sort of trial and error to get there. But what these games were actually able to do was able to rapidly help us develop so that we can actually understand and troubleshoot all the little various hurdles along the way, and then be able to apply those learning models.
Majority of the AI machine learning models, for the most part, being focused very much on disease diagnostics or disease monitoring, which is physiology or things like that. I think we're also seeing an evolution of that into more disease management.
So I see the AI part of it is because this has created a deluge of data. Steve Lebitz at Mass General did a big study, many tens of thousands of ECGs from tens of thousands of patients. Having a Mass General cardiologist overread those is just not practical. It's not scalable, as Malik said. So we have to have AI do that. And we at AliveCor have been fortunate. We have well over 100 million ECGs, and that enables us to generate really good models. We see AI as a tool. Somebody said, is AI going to replace doctors? No, doctors who use AI will replace those who do not.
There's so much content available on demand.
So this group is well aware that COVID has taught us a lot about inflammation and coagulation. We know that these are two separate systems that really are closely connected. They intertwine with one another and start to feed off one another. In that process, they certainly can self-amplify, and over time can lead to thrombosis, both in small and large vessels. This can lead to organ failure and subsequently death, and that certainly has been what's marked the severity of the pandemic itself.
Don't miss any of the programming. All of the content from this entire week is available on demand through December 15th.
We've enjoyed hearing from leadership this week. Let's bring in Dr. Kara. What were your impressions of the day and the program overall?
When I think about some things that will stick with me, There's many poignant moments. Of course, we think about the health equity sessions so much on COVID and moving forward and sort of the way forward in science. So those are things that'll definitely stick with me, but I want to focus on, how it all started on Saturday, opening sessions, with a great scientific discourse about, this guiding light of science taking us towards a new place, because it's been a tough couple of years. And so really an optimistic way to start. Of course, we see the late breaking science. Those are always the most impactful. And this year at Sessions, having these sessions on cardiothoracic surgery, we don't get that many, high level, well done trials in this way. And so these were really impactful and changing clinical practice almost immediately. So that will really stick with me as sort of how we started. And then of course, our second COVID session later on Saturday, where we got a chance to talk to CMOs and CEOs and really hear from their perspective about this industry vaccine partnership and how science can sort of move forward so quickly, and really an exciting tale for cardiovascular disease as well. As I reflect on this one, I can't help but think about next year, as that's our job in CSSP, is to keep one hand today, but one hand tomorrow. And I think we learned a lot. We're excited. I'm pretty sure we're going to be back together to again next year, but we got a lot of takeaways about how to disseminate science around the world in creative ways. And this news desk feel and so many different things that we've done to really help bring others in to this conversation, I think we'll take some of those takeaways with us for next year.
What an incredible showing from all of our 27 programming communities. And great news is all of this great content on demand until December 15th.
Don't forget, we want to hear from you to decide programming for next year. Share your thoughts and ideas while they're fresh on your mind through your council leadership. For AHA TV, I'm Kara Moore.
And I'm Trey Johnson. We'll see you again soon.